Okay, can we start? Can we start? Okay, I'm going to start when you settle down. Okay, so last week and the previous week we started looking at the musculoskeletal system, and we looked at the shoulder, the forearm and the hand. Today what we're going to start looking at is the brachial plexus, which essentially means that we're going to start looking at how the upper limb is innervated. Now, lots of the things that we do today will again be a whole lot of words, but it also will be recapping some of the stuff that we did before, because obviously the innervation is very much related to the muscles that we just covered. Okay, so we looked at all of that, and now we're going to look at the brachial plexus. But before we do that, let's do a quick recall to see how much you remember. So who can give me the answer for the first question? Which statement regarding the humerus is incorrect? Any answers? So again, which statement is incorrect? I've got 1A. Anything else? Okay, let's go through it together then, right? These questions should give you a good idea about how you're doing with the course so far and where you should be concentrating on. They don't give you a good idea. Okay, we're going to go through it together. So teres major, remember it is the muscle that is coming from the scapula to the upper, to the humerus, and it does attach onto the medial lip of the bicipital groove. The head of the humerus is covered by hyaline cartilage because all the articulating surfaces on the shoulder joint is covered by hyaline cartilage. One of the ways to identify which surface of the humerus you're looking at is to identify the lesser tubercle, which should face anteriorly, whereas the greater tubercle faces laterally, yes, posterior and laterally, okay. The deltoid tuberosity is in fact found on the lateral surface of the shaft. That should be pretty much clear because deltoid is coming from here and it's going to insert here, which is on the lateral side of the shaft, isn't it? Yep. And the medial epicondyle is obviously more pronounced. What about the next question about teres minor? Remember, teres minor is one of the rotator cuff muscles. So again, which statement is incorrect? Any takers? E, I've got an E. And I've got a C, so let's go through it together. Teres minor, in fact, arises from the lateral border of the scapula and then inserts onto the greater tubercle, so that's correct. It is one of the posterior rotators, so it will rotate laterally, because it pulls the humerus, it will move it laterally or outwards. It is innervated by the axillary nerve, which is probably a difficult question to give you before the lecture. And like all of the rotator cuff muscles, it stabilizes the joint. So the one that is incorrect is that it can be injured in fractures of the shaft of the humerus, and because it goes nowhere near the shaft, it won't be injured, isn't it? Okay, I think this is one more. Let's talk about this one. Which muscle arises on the medial epicondyle? Where is the medial epicondyle? Okay, to give you a clue, remember that when we did this, you can't get a clue if you talk a lot. So to remind you, we said that all the superficial and the intermediate flexors of the forearm will arise from the medial epicondyle. It's that common flexor origin, right? So which are the ones? Which is not the one? Okay, FES does come from the medial epicondyle. Does FDP come from the medial epicondyle? FDP, is it a superficial or is it a deep flexor? It's deep, isn't it? So it doesn't. Flexor carpi ulnaris does, and pronator teres does. Okay. Extensor carpi ulnaris won't, because this is an extensor, and FDP won't because it is one of the deep flexors, right? And that common flexor origin is not for deep flexors. Everyone good? Oh, there's one more. Okay, yeah. Simultaneous contraction of flexor carpi radialis and extensor carpi radialis leads to simultaneous contraction. Remember, the flexor on its own will flex the carpus, the extensor on its own will extend the carpus, but together these muscles on the radial side will what's it called? Together it will abduct the wrist, isn't it? It moves it outwards together. Good, excellent. I gave you two slides here that explains the movements of the radio-ulnar joints and the condition that we call tennis elbow and golfer's elbow, just to explain it a little bit further, and I'm not going to go through it because we won't have enough time. Okay, so what we're going to talk about today is brachial plexus. You had a lecture on Thursday that explained to you how the nerves arise from the spinal cord and how they arrange. So we're picking up from there. So the brachial plexus is a plexus of nerves that comes out of the spinal cord but rearranges itself quite elaborately so that it can supply both the anterior and the posterior surfaces of the limb. Okay, so it looks really complicated, but that is what it is doing. So whenever you think about brachial plexus and its branches, you should be thinking about branches that will go anterior, because it's supplying the anterior surface of the limb or the anterior compartment, and branches that will go posterior to supply the posterior compartment, because that is in fact the reason why we have the brachial plexus, this elaborate arrangement of nerves. Now the brachial plexus, as you can see here, arises from the anterior rami of spinal nerves C5 to T1. And to remind you of what the anterior rami are, I know you did this extensively on Thursday, so this should be old hat to you. Let's just go through the section. So this here is a cross-section of the spinal cord. In the center we have the gray matter. On the outside we have the white matter. So in the gray matter there is a posterior horn and an anterior horn. The posterior horn by and large is sensory, whereas the anterior horn by and large is motor. So it's receiving or sending sensory nerves or motor nerves respectively. Now from the horns, what happens is that we have roots that come out. So from the posterior or dorsal horn, also called the same thing, you'll have the posterior root or the dorsal root that emerges. The dorsal root has on it the dorsal root ganglion, and that ganglion is the ganglion of the cell bodies in that pathway. Yep. Likewise, the anterior horn or the ventral horn will have an anterior root or a ventral root that is carrying motor fibers. So this is a sensory root, that is a motor root, but what happens to both these roots when they lie in the intervertebral canal is that they combine to form a mixed spinal nerve. So from here on, as we proceed towards the periphery, these nerves are mixed. Mixed meaning that they have both sensory and they have motor fibers. This mixed spinal nerve very quickly divides itself into a dorsal ramus or a posterior ramus and an anterior or ventral ramus. One ramus, many rami. This dorsal ramus is much thinner, and what it does, or much smaller, what it does, it passes quickly to the back to a strip of muscles that are arranged along the vertebral column, and it supplies that strip of muscle and skin over that strip of muscle. So it supplies the deep muscles of the back. This anterior ramus here is the one that we are talking about when we talk about the brachial plexus. The anterior ramus will supply all of the lateral and anterior body walls as well as both the limbs, because limbs grow out as ventral outgrowth in the embryo. So this is where we're looking at. We're looking at these anterior rami here. And I am saying that the anterior rami of C5 to T1 form the roots of the brachial plexus. So the roots of the brachial plexus formed by the anterior rami of C5 to T1. Now, these anterior rami, if they went straight out and supplied the limb, they would just supply the anterior surface. But because we want innervation on the posterior surface as well, it starts combining and dividing to form a network that will go anterior and posteriorly on the limb. So the first thing that this does is these roots combine to form trunks, and the way they do that is C5 and C6 will join to form the upper trunk, C7 continues as the middle trunk, and C8 and T1 will join to form the lower trunk. So the two upper roots and the two lower roots combine to form the upper and lower trunks respectively, and the middle one continues as itself and becomes known as the middle trunk. Everyone good so far? Good. Thanks for answering. Okay, so then what happens is, remember I said the point of all this is to get these anterior and posterior branches. What then happens is every one of these trunks divides into an anterior division and a posterior division. So upper trunk will have an anterior division and a posterior division, so would middle and so would lower trunk. Now all of the posterior divisions quickly joins itself and it forms the posterior cord. So all of the posterior divisions that you're seeing in pink, they are the posterior divisions from each trunk, and they will join to form the posterior cord. Okay. And so through this posterior cord, this was the point of why we had this rearrangement, we would have innervation of all of the posterior compartments of the upper limb. Okay. Now what happens to the upper and lower trunks? They still have their posterior division. They still have anterior divisions. Each one of these has an anterior division that has to come off. So the anterior divisions of the first two, of the upper and the middle trunk, they combine to form what we call the lateral cord. And the lower trunk gives off an anterior division that continues as the medial cord. Okay. So I think you all followed until we got to the trunks. So I'm going to repeat from the trunks to tell you what happens again. Okay. So I said upper, middle, and lower trunks all will divide into an anterior division and a posterior division. The posterior division of all three trunks, you're seeing them in pink, they all come off and they immediately combine to form what we call the posterior cord. That's what you're seeing in pink. That posterior cord is going to supply the posterior compartment. Then the anterior divisions from each of the trunks, the first two anterior divisions, the anterior division from the upper and the middle trunk, combine to form the lateral cord, and the anterior division of the lower trunk continues as the medial cord. Okay. Now these cords, you may wonder why we call them lateral, posterior, and medial. The reason why we call them that is that they are named in relation to the artery that's lying in the axilla. And the artery that's lying in the axilla is the axillary artery. So the lateral cord is lateral to the axillary artery, the medial cord is medial to the axillary artery, and the posterior cord is posterior to the axillary artery. Okay. Now, when we actually get innervation of the muscles and compartments of the limb, we actually get innervation by the nerves. So these cords each divide to give us a number of nerves, and for us we're only going to concentrate on the 5 biggest nerves that supply the upper limb, right? So if we look at those 5 biggest nerves, and if we take the branches, these are called the branches are actually going to go to the muscles and supply the muscles. Up until now it was all about the rearrangement. Okay, so the branches from the from the lateral cord, the one in green, that's the lateral cord, it continues, and its terminal branch, or how it continues, whatever's left in it, is called the muscular cutaneous nerve. So muscular cutaneous means there's a muscular part and there's a cutaneous part. Muscular means it supplies muscle. Cutaneous means it supplies skin. So muscular cutaneous nerve. And we'll talk about what it supplies just now. So the lateral cord, the main branch of it, is the muscular cutaneous nerve. If we look at the medial cord, its main branch, or it continues right till the very end, as the ulnar nerve. Okay, so muscular cutaneous from the lateral cord and ulnar nerve from the medial cord. Okay. The posterior cord also gives off branches, but it continues, and its biggest branch, its terminal branch, is called the radial nerve. So these are the three terminal branches of these cords. It means that these cords continue to the very end as these nerves: the muscular cutaneous, the radial, and the ulnar nerve. Now, besides the radial nerve, the posterior cord also gives off another little branch, and that little branch is called the axillary nerve. It gives off this branch in the axilla, and it supplies the deltoid muscle and teres minor, which we've mentioned a few times already. So you're familiar with that one. The posterior cord is giving us radial nerve, which is its terminal branch, but in the axilla it also gives off the axillary nerve. Okay. Everyone with me? Yes, good. Okay. So then what happens, I told you we're going to do 5 branches. So the other major big branch of this plexus is called the median nerve. Now when I say median nerve, people always confuse it with medial, so I'm going to emphasize the N and say median nerve, but it's the median nerve, right? So that you understand and you're not going to get it mixed up. So the median nerve, what happens to it is that it comes from 2 places. The lateral cord and the medial cord both give off roots that join to form this median or median nerve. Okay, so this here is the median nerve. It has a lateral root from the lateral cord and a medial root from the medial cord. It's called the median nerve. Okay. So that is the brachial plexus and its branches that we're going to study, and so now we're going to look at each one in detail. Does anyone want me to go through this again? Are you okay? You're good. Excellent. Okay, so if you look here, these numbers here, C5, C6, 7, if you work backwards from the muscular cutaneous nerve, you can work out which spinal cord segments contribute to this nerve. Yeah? So that's what these numbers refer to, and we'll talk about it a little bit just now. The other branch, so we've spoken about the branches from the cords, but besides branches from the cords, the brachial plexus also gives off branches from the roots and the trunks. We're not going to do any of those branches from the roots and the trunks, except for this one here that comes off from the roots of C5, 6, and 7, and passes all the way down. As it passes down, it lies on serratus anterior muscle, and it supplies the serratus anterior muscle. Okay, so this nerve here is the long thoracic nerve. And that's the only branch we're going to talk about from the roots, trunks, and divisions. So now let's look at this in a little bit more detail. So this here is showing you a diagram. It's showing you a diagram of the brachial plexus. The roots of the brachial plexus is what you're seeing here. So 1, 2, 3, 4, and 5 just underneath that rib. Those are the roots of the brachial plexus. You will find the roots of the brachial plexus in the neck. They are usually between the scalenus anterior and medius muscles. If you've never heard of those muscles before, that's okay. Okay, but this is where we'll find the roots. We'll find them deep in the neck. Okay. The roots then form the trunks, which we spoke about, and we said the upper 2 roots join to form the upper trunk. C7 continues as the middle trunk, and C8 and T1 combine to form the lower trunk. These trunks you would find underneath the clavicle. So if you look underneath the clavicle, you would find those trunks. Okay. And then the divisions, branches, and cords we will find in the axilla. They're called lateral, posterior, and medial cords. due to their relationship to the axillary artery, which I'll show you just now. Okay, so if you look here, here's the lateral cord that we're looking at here. I said the terminal branch, or the main branch of the lateral cord, was a nerve called the median nerve. This would be the median nerve. And the median nerve will pierce a muscle called coracobrachialis muscle, which we'll talk about just now. If we look at the posterior cord, this is its terminal branch going all the way down. That will wind around the humerus, and that is called the radial nerve. If we look at the medial cord here, its terminal branch, the big branch here that we're seeing, that would be the ulnar nerve. And this branch that is formed by parts of both the medial and lateral cord, this is going to be called the median nerve, or the median nerve. Okay. Everyone okay? Good. So if you compress your muscles just underneath your clavicle for long enough, you may get a tingling sensation in your upper limb, and that's because you're compressing these trunks of the brachial plexus there. Okay, so now brachial plexus, we can have a number of injuries, and when we're talking about the nerves just now, independently, we're also going to talk about where each nerve can get injured and what would be the effect of such an injury. But besides the nerves, those branches that I spoke about just now, we can also get the brachial plexus getting injured, and the brachial plexus can get injured here in the axilla or in the neck or under the clavicle. Now, brachial plexus injuries are divided into different types. They're divided into an upper plexus or a superior plexus injury, which usually involves the upper roots of the brachial plexus, or it can be a lower plexus or an inferior plexus injury, and that could affect the lower roots of the brachial plexus. There's certain particular positions that the limb takes when these nerves get injured, and we'll work backwards just now as we work through the nerves, and you'll understand why it takes those positions. So if you look at the C5 or the C6, the C5, C6 or the upper plexus injury, this usually occurs, or very commonly can occur, during delivery of a baby, when the limb is pulled up and abducted, and so it stretches this upper cords here of the brachial plexus. It can also occur in other ways, but that's one of the common ways in which it occurs. It's called the Duchenne palsy, or the Waiter's tip palsy. And the reason why it's called Waiter's tip palsy is because in the old days, when people used to go to a restaurant, the waiter never got a tip, but in a way in which he would ask for a tip is as he's walking away, he would put his limb out that way and his hand towards the back, and someone would place money in their palm. So that's the Waiter's tip position. And that's how this limb would, the position that this limb would take if there's an upper plexus injury. Now, to understand why that happens, we're going to talk about the nerves and the muscles that they supply, and we'll work backwards to this. So to show you exactly the same thing that I showed you just now, but on a cadaver, so there is the axillary artery here, passing down in red. That axillary artery is obviously lying in the axilla, and these nerves that we were talking about were these nerves around it. Now, this M shape here that we're looking at is when you go into the dissection hall or the anatomy lab and you're working out how to identify these nerves, the common way in which we all of us try to figure out is that we look for this M. So this center limb here of the M, the center limb of the M here is the median nerve, and these two parts are its contributions from the lateral cord and the medial cord respectively. The sides of the M are made up of the musculocutaneous nerve and the ulnar nerve. Now, it looks quite abstract when you're looking at it here, but when we go to the anatomy lab, it will be much more clearer. So the trick when identifying these nerves in the anatomy lab is to look for this M, and this M is normally the pillars that we were talking about: median nerve, musculocutaneous nerve, and ulnar nerve. Okay. Now, what is wrong with this person? So this is what we call a winged scapula. Now, a few people in the lab 2 weeks ago was asking me what a winged scapula looks like, and that's what a winged scapula looks like. So So this is caused by damage to the long thoracic nerve. Remember we spoke about it just now. It's the nerve that comes down from the roots of C5, C6 and C7, passes all the way down in serratus anterior, and as it passes down it innervates serratus anterior. The function of serratus anterior is to keep the scapula, like you can see on this side, against the rib cage. So when this nerve is damaged, the scapula does not lie against the rib cage, and therefore it sticks out, and that is called a winged scapula. Okay. Now let's take all of the nerves independently. So let's look first at the axillary and radial nerves. Now remember just now we spoke about this brachial plexus. I told you all the three posterior divisions of the trunk combine to form the posterior cord, and from the posterior cord we get two main branches, the radial nerve, which is its terminal branch, and in the axilla we get the axillary nerve. So we're going to talk about these two together now. So if we look there, this is a view of the upper limb, the bones of the upper limb. What happens with these nerves is the posterior cord comes off, and as the posterior cord comes off, it continues as the radial nerve. The radial nerve passes down into the arm, and as it passes into the arm, it will pass posteriorly. So this is anterior humerus, it will pass behind the humerus. And as it passes behind the humerus, it's winding around this groove that lies in the humerus called the spiral groove or the radial groove. And in that way it goes to lie posteriorly in the arm, so in the posterior. So again, it comes off in the ulna. It doesn't come off in the ulna. It comes off in the axilla. As it comes off in the axilla, it quickly passes posteriorly by winding around the spiral groove of the humerus, and so lies in the posterior compartment. In the posterior compartment, it will obviously supply the muscles of the posterior arm, which are triceps. Yes, so it's triceps that it's going to supply there, and then as it passes downwards to come towards the forearm, it lies under the cover of brachioradialis. Remember brachioradialis? It's this bulk of muscle that you see here in your forearm. It lies under brachioradialis and passes into the forearm. In the forearm, it will divide into a deep branch and a superficial branch. The superficial branch comes all the way down, and it lies in this snuff box, the anatomical snuff box. So if you pick your thumb up like you're hitchhiking, you'll see the depression at the base of that, and that is where you will find the radial nerve. So that's the superficial branch of the radial nerve. The deep branch of the radial nerve will pass into the posterior forearm, and it will supply all the muscles of that compartment. I think I have that on that already. So that's the radial nerve. The axillary nerve, on the other hand, comes off very quickly in the axilla, and as it comes off in the axilla, it quickly passes around the surgical neck, so it will pass posteriorly and wind around the surgical neck of the humerus, and it will supply deltoid and teres minor. So it supplies deltoid and teres minor. So the axillary nerve is supplying skin, and it supplies skin over the muscles that it's innervating, and in this case it will be deltoid muscle. So all of the skin here, where we see deltoid muscle, is supplied by the axillary nerve. The radial nerve supplies a strip of skin going all the way down in our posterior compartment of our arm and forearm and hands. But we'll talk about hands separately just now. Everyone good? Okay, so to recap what I said just now and to show you what I mean. So here is the posterior cord, there's the axillary artery, and remember that there will be the medial cord, that will be radial cord, and behind is the posterior cord, and for that reason the axillary artery is cut off, so you can see the posterior cord. The posterior cord quickly gives off the axillary nerve, which is winding around the surgical neck, and this is where we're seeing it here. This is the surgical neck of the humerus, and these branches that we're looking at here is the axillary nerve. So to orientate you on this specimen, this is posterior, this is deltoid that is reflected, this here would be? Not the last time I checked, it won't be teres minor. This here would be teres minor, this here would be infraspinatus, good. And this here is triceps, so that will be the long head of triceps, and this here would be the lateral head of triceps. So this here is the axillary nerve. So it winds around the cervical neck. We spoke about it many times, so it is at risk of damage when there is fracture of the cervical neck of the humerus. Right. And the effect of that, the effect of damage of the axillary nerve, would be loss of function of deltoid and teres. Yes, you can read, but what will be the effect of that? What will happen to us? Yes, it's loss of abduction, isn't it? Because deltoid is our power of abduction. So that's our major loss or major effect. Obviously, the skin over deltoid is what it's going to supply, so the effect of that damage will also be loss of sensation over the lateral aspect of the arm. Okay, the radial nerve, if we look here, there's the diagram. The radial nerve comes off in the axilla, passes quickly posteriorly by winding around this radial groove. When it passes in the radial groove, it actually lies against the bone. And for this reason, when there's fractures of this area here, it would cause damage of the nerve itself. So any fracture of the shaft, especially in the mid-shaft region, would be where we would get damage of the radial nerve. The good landmark to actually know when you're looking for radial nerve, actually radial nerve is easy because anything that passes into the posterior arm is the radial nerve. But if you had to look for it, you will look for it between the long and lateral heads of triceps, because that is the position of the spiral groove. Okay. From there, as it goes down, I told you it passes under brachioradialis. So this is the nerve that we're looking at here. It's coming off in the axilla, passing quickly posteriorly, and from here it will wind around that spiral groove. Okay. Again, where would it be at risk of fracture? It would be at risk of fracture here, at risk of injury here in fractures of the mid-shaft of the humerus. But it is also a nerve that can be damaged in the axilla itself, and typically it's called, when it gets damaged in the axilla, it's called the Saturday night palsy. It comes from this old story of, when guys, now it's girls as well, but guys in the old days used to go out and they used to get drunk, and then they used to come back on a Saturday night. When they came back home or wherever, they fell asleep, and often they fell asleep with their hand over their chair. And when they fell asleep with their hand over the chair, they would stretch the nerve there, and so it was called a Saturday night palsy, and they ended up with all the signs or effects of damage to the radial nerve or to the posterior cord. It's also called the crutch palsy, and for the reason why it's called the crutch palsy is because when somebody is fitted with crutches, and if they're fitted with crutches that are too high for them, they would end up with having to go over the crutch like that and so stretch the nerve in the axilla as well. The typical effect of any damage of the radial nerve, especially high up, is what we call wrist drop. And the reason why it's called wrist drop is because the radial nerve will supply all the muscles of the arm, but it also supplies all the muscles of the posterior forearm as well. And all the muscles of the posterior forearm is what causes us to extend our wrist. And so when they have a lesion of this, the hand ends up like this, they can't extend their wrist. Okay, so that is called the wrist drop. That's what you're seeing in this image here. Okay, so effect of lesion, depending where the lesion is, if the lesion is high up, you will have the effect on the posterior arm muscles as well as the forearm muscles. If the lesion is lower down, like below the elbow joint, then the posterior arm muscles will be saved, but you will still have wrist drop due to loss of function of the posterior forearm muscles. Anyone lost so far? You following? That should mean yes. Okay. So I said that as the radial nerve, it came underneath or between the two heads of triceps, and then it comes into the forearm, and the way to find it in the forearm is that it always passes under brachioradialis. Now, unfortunately, in this picture here, brachioradialis is removed, but this is where you will find the radial nerve. It will be under the cover of brachioradialis. As it passes into the forearm, it will divide into superficial and deep branches. The deep branch is going to supply all the extensors of the forearm. The superficial branch is the one that we would feel in the anatomical snuff box. So it's going all along the thumb side of our forearm towards the anatomical snuff box. Okay. Obviously, it can be injured in the forearm as well. generally it will get injured due to fractures of the radius, but it can also get injured in compression lesions. So sometimes there's a injury to the forearm compartment, and what happens in that injury is that it could rupture one of the blood vessels, and when the blood vessels rupture, the fluid starts accumulating in that compartment, and so you can get compression of the nerve. That's called compression syndrome. Okay, so it can get injured in compression syndrome as well. So I spoke to you extensively now about the muscles that it supplies and the skin, and you should be able to fill that last block there. So now when we go to the hand, I just want to explain to you what happens to the innervation of the skin of the hand. Now this here is the back of your hand here. So what happens with the radial nerve? It's passing in this anatomical snuff box, and then it gives us branches for each of the lateral 3.5 digits. So 1, 2, 3, and half of the ring finger will be supplied by the radial nerve on the posterior aspect. So we're talking about the posterior aspect, the dorsum of your hand, where you can see your skin. That's the posterior aspect. The opposite side, where is the palm of your hand, that's called the palmar aspect. So this here supplies skin on the 3.5 digits. This picture that I've got here is from Gray's Anatomy for students. There's a little error here because this half here should also be colored in green. So it's 3.5 digits. Okay, remember that. Okay, so if we move on and we look at the median nerve, the median nerve, if you remember now from the beginning of the lecture, we spoke about the brachial plexus, and we said that the median nerve is actually formed by a root that comes off from the lateral cord and a root that comes off from the medial cord. They combine and they form the median nerve. Now the median nerve, if we look at it in a diagram, again we're looking at the anterior view of the arm. The median nerve comes from these two cords. It passes straight down through the middle of the arm into a space in the anterior part of our elbow joint that we call the cubital fossa, and then from there it passes into the forearm and then into the hand by passing under the carpal tunnel. Okay. Its distribution is that it does not supply anything in the arm. So the median nerve supplies nothing in the arm. In the forearm, it supplies all the forearm muscles except for flexor carpi ulnaris and half of flexor digitorum profundus. So the half of FDP is the half that's found on the ulnar side. So on the ulnar side, it doesn't supply flexor carpi ulnaris and half of FDP. Okay, otherwise it supplies absolutely everything in the forearm. In the hand, it supplies, remember we spoke about the thenar muscles here? So it supplies those thenar muscles. The thenar muscles are made up of a opponent, an abductor, and a flexor. Remember? Right, so it supplies all of that. It supplies the opponents, the abductor, and the flexor that make up the thenar muscles here. And it also supplies two lumbricals on the lateral side. So on this side of your hand, it supplies the thenar eminence here, all of the muscles, and it supplies these two lumbricals. Now, if you remember the lumbricals, just to recap, they do this action where they flex these joints, which are the metacarpal phalangeal joints, and they extend the interphalangeal joints. Remember? That's just a recap. Now, the way to remember median nerve is that it supplies everything except half of FDP and flexor carpi ulnaris, and then in the hand there's this mnemonic called loaf. It should actually be two loaves because it's 2L is the lumbricals, and the opponents, abductor, and flexor pollicis brevis of the thenar eminence. Okay. In terms of skin, the median nerve, you need to just pay attention here. So the median nerve will supply skin of these 3.5 digits all the way on the palmar side and on the reverse side up to the nail bed, so up to the end here. So median nerve all of there and up to the nail bed. Everyone good? So for that reason, remember when we were looking at Alma Jones, when she was being examined, she was asked whether she had sensation on this side of the ring finger and on that side of the ring finger, and that was to decide whether it was the median nerve or median nerve and the nerve that supplies this side of the ring finger, which is the ulnar nerve. Okay, so median and ulnar. So it supplies 3.5 fingers here and up to the nail beds on the reverse side, on the dorsal side. Okay, so if you look at the median nerve now, we'll see here's the median nerve. I told you it's formed by the two roots, passes straight down the arm with no branches, and as it comes here into the cubital fossa, it lies in the fossa, which I'll show you just now. So if you look here in this diagram, this here is the median nerve. You can see it passes almost directly in the middle of the arm. It passes down and it enters this area here, which is the elbow region. Here's your medial epicondyle. That would be lateral on that side. This would be towards the hand, and this would be from the arm. So this muscle that we can see going downwards, that muscle there would be biceps. Next to biceps is the brachial artery, and next to that is the median nerve. So this is in the cubital fossa. The reason why you should actually know this is because in this region of the elbow, all of the nerves that are passing down pass down there, and they're frequently pinned in a spot test. So the median nerve is passing into the cubital fossa. If you look at this, there's a nerve that's coming here, and this nerve is going behind the medial epicondyle. That's the ulnar nerve, which we're going to do just now. And the last major nerve in this region is the radial nerve, and you would find it under brachioradialis at the elbow region. Okay. So the median nerve, as it goes into the forearm, its typical relation is that it is lying between FDS, this is flexor digitorum superficialis, that's reflected, and flexor digitorum profundus. So if you look for it in the forearm, you would look between FDS, superficialis, and profundus. Okay, and then from there, I told you it will pass down into the carpal tunnel. Now, before it passes into the carpal tunnel, what it does is that it gives off a superficial branch, and this superficial branch that it gives off will supply the skin on the palm of the hand. Okay. For that reason, when people have carpal tunnel syndrome, the skin on the palm of the hand still remains with normal sensation, and they actually feel the tingling sensations on their fingers rather than in their palms, right? Because this superficial branch comes off before. So obviously you know where this is at risk. It will be at risk in anything that damages the forearm, but most especially for us, and the case that we're doing is that it is at risk in carpal tunnel syndrome or any compression that would affect the carpal tunnel. Now what happens when someone has carpal tunnel syndrome? They end up with their hand looking something like this. This is called ape hand. Okay, and in ape hand what happens is that they lose the opposition of their thumb, and for that reason it's called ape hand. The reason they lose the opposition of the thumb is that the median nerve supplies those muscles that we just called loaf, which is the muscles here. Okay, so at risk of injury in the carpal tunnel, we know what the loss of function of the median nerve at this level would be. It would be what we call ape hand, and the most significant thing about the ape hand is there's loss of opposition. The fingers here can still flex at the interphalangeal joint because all of the innervation here in the forearm has been retained. Yep? Everyone good? Okay. As opposed to, sorry, not that. I just did all of that and I explained to you the whole thing there. As opposed to a median injury above the elbow. So a median injury above the elbow would mean that there is loss of function of all the flexor forearm muscles, except for that half that it doesn't supply, half of FCP and flexor carpi ulnaris. So what happens with the median nerve injury above the elbow is that the person still ends up with loss of opposition and all of the things of a median nerve injury at the carpal tunnel. But in addition to that, they will lose the ability to flex the interphalangeal joints, isn't it? And the reason for that is that all of these flexor muscles have been lost. They will also have weakness in wrist flexion, and the weakness in wrist flexion is because flexor carpi radialis is also not working. Everyone good? You should be able to differentiate a median nerve injury at the carpal tunnel and a median nerve injury at the forearm or index below. Okay. And I've explained all of that I just told you just now. Okay, the next nerve that we're going to do is the ulnar nerve. The ulnar nerve, if you remember here from the brachial plexus, the ulnar nerve is the continuation of the medial cord. Now when you think about median nerve and ulnar nerve, you should think of them as partners in supplying the forearm and hand. So like I said just now, the median nerve supplies everything in the forearm except for those muscles that I mentioned. And so what the ulnar nerve does, it supplies the rest of those forearm muscles. And likewise in the hand, the ulnar nerve supplies all of the muscles in the hand except for those loaf muscles that I told you about. So they are partners in innervating the anterior compartments of the forearm and hand. So if you look at the ulnar nerve, its course is that it passes into the axilla, straight down the arm, gives off no branches, then passes behind the medial epicondyle where you can roll it on your own forearm. And that's the part where if you hit it, it gives you that tingling, funny sensation in your hand. Sometimes if you lean or sleep on one side of your elbow, you may get up with pins and needles. And when you get up with pins and needles next time, you should notice that it's on 1.5 digits and it's not on the others. Okay. Okay, so the distribution of the ulnar nerve, I told you it's the partner of the median nerve. So those muscles that the median nerve didn't supply in the anterior forearm, which is flexor carpi ulnaris and half of FCP, is what the ulnar nerve is going to supply. And then likewise, it supplies all the muscles of the hand except for the thenar muscles and the lateral two lumbricals, which is supplied by the median nerve. In terms of skin, what the ulnar nerve supplies is this 1.5 fingers. It supplies it on both the palmar surface and the dorsal surface, so completely 1.5 digits. Okay, so ulnar nerve again, I'm showing you the course here, passes down underneath medial epicondyle, then ends up in the forearm. It is at risk of injury when the medial epicondyle is fractured because it passes right against the medial epicondyle. The medial epicondyle is frequently fractured in sport injuries. That's where it is most vulnerable. The other place where ulnar nerve is really susceptible is if you look at the ulnar nerve, as it passes behind the medial epicondyle, it passes into the forearm, and as it passes into the forearm, it does not pass under the carpal tunnel. So unlike median nerve, which went under or through the carpal tunnel, it passes over the carpal tunnel. And for this reason, it is the nerve when people unfortunately slash their wrist, this is the nerve that commonly gets injured. So they may not end up with the result that they wanted, but what they would end up is with an ulnar nerve lesion. So this is the nerve that is at risk there. What the ulnar nerve supplies, I told you, is that it will supply all of the hand muscles, and all of the hand muscles is everything except for the thenar muscles and the lateral two lumbricals. Now what happens when we have an ulnar nerve injury is that the hand ends up in this kind of position, and the reason why the hand ends up in this kind of position is because there is loss of flexion of the ring and little fingers, and so they stay up, whereas these ones can flex. So typically with the ulnar nerve lesion is that you will ask someone to hold a glass, well, hopefully not a glass, ask them to hold something cylindrical, that may be a plastic tube, and what you would find is that they can flex these fingers, but these two fingers on the outside, the little and ring finger, can't be flexed. And so that is what is called an ulnar claw hand. These two are straight, but these are flexed. Okay, so the ulnar nerve passes the hand and supplies 1.5 digits. I told you that already. It's also sometimes called biker's palsy when it gets damaged in the wrist region, and the reason for that is when people ride bikes and they hold the handbars of the bike, and over long distances, they frequently compress the nerve as it's passing over the retinaculum, and so they will also end up with these tingling sensations. Okay, so if you ride a bike for a long distance over the weekend and work out your ulnar nerve distribution. The last nerve that I'm going to tell you about is the nerve that comes off from the lateral cord. That's called musculocutaneous. By and large, it's the easiest of all the nerves. So it comes off in the axilla. As it goes into the arm, it will pierce the coracobrachialis muscle, and then it will supply all the muscles of the anterior compartment of the arm. So it supplies the anterior compartment muscles, which is biceps, brachialis, and coracobrachialis, which we're not doing much of, but it is a useful muscle to identify this nerve because the nerve pierces this muscle. So it supplies all the muscles of the anterior compartment, so that's the muscular part of its name. After that, it becomes cutaneous, and it becomes known as the lateral cutaneous nerve of the forearm, and it supplies the skin over this area of your forearm. So the muscular part refers to the fact that it supplies all of the anterior compartment of the arm, and the cutaneous part refers to the fact that it then becomes cutaneous and supplies skin on your forearm, like in the shaded area. Okay, so just a few things to sum up. Remember what I said about the muscles of the hand. The ulnar nerve supplies all the muscles of the hand except the thenar muscles, which is the opponents, abductor, and flexor pollicis brevis, and it supplies two lumbricals to these two fingers here. That's your index and your middle finger. So that's a useful mnemonic to remember. The opposite of this is the innervation of the forearm muscles. And remember, in the forearm, it's the opposite way. The median nerve supplies all the muscles of the forearm, except for flexor carpi ulnaris and this ulnar half of flexor digitorum profundus. Okay, so that's a useful thing to remember. Again, to recap the innervation of the hand, remember I told you just now that the median nerve will supply 3.5 fingers up to and including the nail beds on the posterior surface of the hand. The ulnar nerve supplies 1.5 fingers, and it supplies 1.5 fingers on both the palmar and the dorsal surfaces, and the last part, whatever's left here, is supplied by the radial nerve. That is the lateral 3.5 fingers on the dorsum of the hand. Okay, except for the nail beds. Okay, so to recap what we did just now, there's 3 sets of fractures. This first fracture here is at the level of the shaft. Well, there's 3 different ones, but they're all in the mid-shaft. What nerve do you think would be injured? Radial. The radial nerve, good. Here, where is the fracture? Can you see it? No? So if you look here carefully, can you see there? There's a fracture. What area of bone is that? This here is the ulna. So if you see the ulna, so this here is the medial epicondyle, isn't it? Okay, what nerve is at risk of injury there? The ulnar nerve, good. And the last one here, this is clear, this is a fracture of the cervical neck, and the nerve that is at risk there is the axillary nerve. Remember, you should know the course of the nerve, you should know what they supply, and from that you should be able to work out what the effect of a lesion is. Yes? Okay, we're going to practice some of this in SGS 7 when we look at some cases, so you should have some practice before the exam. The last thing that I just want to double check with you that you perfectly understand. So there's this concept of what we call cutaneous innervation, and when we're talking about cutaneous innervation or peripheral innervation, we're talking about the area of skin supplied by a peripheral nerve. Peripheral nerves are the nerves we just did just now: axillary, radial, musculocutaneous, median, ulnar. Those are all examples of peripheral nerves. So when we ask what is the cutaneous innervation of the axillary nerve, for example, we ask you what area of skin is supplied by the axillary nerve. Everyone happy with that? Okay. As opposed to the alternate concept, which is the concept of a dermatome. Now remember, when we looked at all of these nerves, we saw that more than one spinal cord segment actually contributed to the formation of that nerve. Now each of those spinal cord segments also supply regions of skin, and that region of skin supplied by a single spinal cord segment is called a dermatome. For example, here, if we look at the axillary nerve, we would say that its cutaneous distribution is at the level of, or is at the lateral aspect of the skin on the superior, the skin on the superior aspect of the lateral arm is where the axillary nerve is supplying its cutaneous innervation. The axillary nerve is actually made up of C4 and 5, And where is that dermatome? It would be here and here. So it's two separate areas. Can you see that? So if I ask you for the dermatome, which area of skin is supplied by C5, that's specifically an area, not including the whole of axillary nerve distribution. It's a specific region of the axillary nerve distribution. Now for us, we're not going to do the separate areas of dermatomes. You should actually just know that there is dermatomes. It's actually not as hard to learn off as it looks, because it goes in a sequential order. If you go from here, it's normally C4, C5, C6, C7, C8, T1, because it's related to embryology. But we're not going to do the different areas of the dermatomes now. The reason why it is important to understand is the concept. If you're trying to work out whether it is a peripheral nerve lesion or a spinal cord lesion, the idea is to look at different dermatomes in that peripheral nerve to work out whether the loss of sensation is across the entire peripheral nerve spinal cord segment or related to only one single segment. Okay, I think we'll stop there. Sorry, one thing to tell you before you go. So you should have all received the adaptive tutorial email that gives you the link to do the adaptive tutorial. Please have a go at that. I know that there is a problem with the forearm bones question, but still continue and have a go at it. It's just that if we have to fix that question up, it will take 2 or 3 weeks before we can release it again. So you might as well just have a go at it. The correct version will be in the next tutorial as well. And that's why when you work on a